Thank you all for having me. I'm here today to speak about remote patient monitoring. And a lot of FQHCs, actually next slide please. So first of all, the genie's out of the bottle. And what I mean by that is access to care remotely. Since the pandemic, things have changed. Obviously, overnight, FQHCs had to move to utilizing telehealth. And now increasingly with the Delta variant and everything else going on with COVID, getting access to patients remotely and providing care is going to be really important. And so that's what I mean by what genie's out of the bottle. I'm going to talk a little bit about remote patient monitoring, what it is. Usually people just think of the devices, but it involves 3 different steps, which we'll talk about. And so the types of RPM devices out there, connectivity, some best practices, financial sustainability, which is going to be really important because that's another thing that you as FQHCs are thinking about. And then the power of the data, which I think is one of the key aspects of RPM. The next slide, please. It may be easier if I just do it, right? Okay, there we go. And I should also say I've got Benjamin Lefevre online as well, and so Ben will be chiming in as he said with certain cells. So the remote patient monitoring really involves 3 distinct parts, right? And I've put the first part out there, driving patient adherence and behavior change and health outcomes, because I think it's the most important. Once you get devices into a patient's hands and the data starts flowing, that's just the first part of RPM. What's really powerful and what really we want to improve healthcare outcomes is empowering that patient to take a proactive approach in their health and guiding them to create behavior change. And so once you get the device, you set them up with a patient with a device, the data starts to flow. Really what you need is to have an FTE or someone that is checking in with the patient and making sure that they're helping them achieve that goal of behavior change. And so you as an FQHC have to decide, is that something that you have the capacity to do in-house? Do we need to get an do we have to hire health coaches, maybe an MA, so on and so forth? And then obviously monitoring and acting upon that clinical data that is coming in. And that can get overwhelming as well, because once you start getting this input of data and you think about patients, if you take hypertension and we have 2 readings maybe a day coming in, and then you have maybe readings that are out of range, how do you act upon that? What do you have the mechanisms in place to make sure that you are, like we said, we're taking care of those patients and when those readings come in? So I'm not going to go into this. These slides will be available to you for the sake of time, but this is, if you haven't heard about it, the Million Hearts program was a program actually put forward by NAC a few years ago, and it was basically self-reporting devices that for blood pressure that were given, I think, to about 7 health centers across the country. And so if you go and click on this link in the presentation, you'll be able to take a look at some of the outcomes, which are really staggering. Same thing with this, RPM has been studied before. The VA was probably the first institution that started really looking into remote patient monitoring, the power of RPM. And so for the sake of time, you guys can go into these, the study and see a little bit more about it. The next slide, yeah. So with this being said, I kind of, I know some of you in here, I kind of want to get an understanding, where are you in your RPM journey? And the question right now is, should we begin or should we not? Many of you have received funding. If you received the HRSA hypertension grant, you may have applied for the FCC grant and received some funding to do telehealth and RPM. And the question is, should we begin? How do we begin? There's so many different vendors out there. What are the best types of devices? And with the pandemic now continuing to rage, I don't even know, it's sort of, I think it's becoming endemic. And we don't know if there's a light at the end of the tunnel. And so the question is, for these patients who are most vulnerable, who are frequent flyers, how do we keep track of them who have multiple chronic conditions? We don't want them to come into the FQHC when it's not absolutely necessary into your health center. How do we keep track of them? And so once again, the questions you probably are asking yourselves, is this something that we're going to do in-house if we're going to start? Is it something that we're going to work with a vendor partner to help, as I said, with the FTEs, or maybe a hybrid? Maybe we'll start with a partner, get some help with the FTEs, and then try and build this out on our own. And so things that you will probably be thinking about currently. So the benefits of RPM, basically is a way to manage a growing number of patient populations with chronic disease, improve patient satisfaction outcomes, and as the shift to value-based care happens, as I said, understanding what happens with that, the power of that data that you're going to get. So when you have a patient that has multiple chronic conditions, in a normal setting, the only time that you're getting their blood pressure or their glucose readings is maybe once a year or twice a year when that patient comes into the clinic, right? And then you basically take their blood pressure or you weigh them. The power of RPM really is now having data in real time. And as I said, with that data comes responsibility. And that's the other piece that I think you guys are thinking about, which is, from a point of, if I'm getting all of this data, how do I manage the data? How do I actually then utilize that data to improve that patient's health, right? And so improved access to care. And with that, then intervening in certain specific times, and what we want to do is really then reduce the number of hospital admissions, the number of times that the patient goes to the EHR, and obviously in the long run saving costs, right? So with that, there's key functionalities and requirements that you need to consider when selecting the correct remote patient monitoring solution for your FQHC. The first and foremost is patient usability. As I said, there's so many different devices out there. There's so many different companies. We all have wearables now if you have an Apple Watch. But for the patient population that we serve, not all those devices are going to be the best suited. So in my experience, if you find devices where the patient requires Wi-Fi or has to understand how to maybe connect via Bluetooth, those are types of devices that may not be best suited for our patient population. So you really have to think about the patients that you're serving, if they have to download an app, right? And I think we found this out during the pandemic with telehealth. Everyone had a telehealth app, but the patients that we serve, if you're a patient and you don't have, you have a limited amount of data on your phone and you have to download the app, go into the app, those are real challenges. So we have to think about how is this device going to be used by the patient. I think EHR interfacing or integration is another thing that FQHCs, US FQHCs are always looking at. With remote patient monitoring being so new, there's limited, the amount of vendors that actually have interfacing with your particular EHR may be limited. So you have to think about that. And we'll talk a little bit more about, and even when there is interfacing, what type of data is flowing into your EHR? Is it just raw data? Is that data being converted into structured data and then put into EHR? Things that you have to think about. And so from a reporting and analytics perspective, patient reminders, is the patient getting a reminder when you don't get a reading for 3 days from the patient? How is that sending a reminder? If it's an email and the patient either doesn't have access to email or it's unreliable, then that solution is probably not best suited for you, right? If it's a text message or another way that the patient's getting a reminder, or maybe you get an alert and someone from your team calls the patient to say, hey, we haven't gotten a reading from you. So all of these things to think about, all right? And then I think hardware compatibility, I'll go into that a little bit. There are many solutions out there which are not, which are software. I guess what the better way to say is you want a solution that is hardware agnostic, right? Because as technology continues to change, you want the software to dictate and the connectivity to a particular type of hardware and the solution. So as that happens, there's some vendors out there that you can only use a particular one type of hardware, and if that's the case and you're stuck with that, then as advances happen and they may not advance as quickly as you would like them to, so on and so forth. So hardware compatibility and obviously cost and sustainability. And that is going to be something that's really important. We'll talk a little bit about, there's good news in Arizona. I know we have health centers from Nevada. We're not there yet, but there is good news for Arizona's for reimbursement for RPM. So we'll talk a little bit about that as well. All right. So the challenge is finding the right solution. All right. The first part is the devices. And in the work that I've done with FQHCs and AACCNs, I think the best type of device is the ones that have a cellular chip. So what that means is that the particular device, right, this is high-tech devices. These particular devices, the data flows directly from the device into a portal or somewhere, right? And this is raw data, obviously. So the patient, in this case, doesn't really need to have Wi-Fi in the home. They don't need to fiddle around and try and connect things via Bluetooth. The chip inside, just like the chip inside your phone, will send that data directly into a portal. So that's the first piece. I think interoperability, as I said before, you want a solution that is hardware agnostic so that you can have different devices, obviously those that are approved. And then sustainability piece, as I said, once again, so Arizona, and Ben can chime in here, but Medicaid has now, Arizona Medicaid, you are now able to reimburse fee-for-service for RPM. This is really big news. And so the challenge is it is time-based, just like with Medicare. So it's an all or nothing program. So you're able to get reimbursed, but you have to actually put in the time with the patient, and the amount of time is something that you need to think about, okay? All right. So the types of devices with the host of hypertension grant, most of the devices that you want now are going to require to be connected devices, so high-tech devices. So ones in which the patient is not self-reporting data, in which the data is flowing directly into the EHR, okay? We've talked a little bit about Bluetooth versus Wi-Fi versus cellular. In my opinion, I think the devices that work best in the FQHC world are cellular devices. That's just my opinion. It's kind of in different pilot projects that we've studied, cellular devices seem to work best. And then once again, does the vendor require an app to be downloaded by the patient in order to utilize the platform? Something else that you need to think about, once again, with the limited, as I said, access to data that these patients may have. So the devices are one piece. I think that the secret sauce, though, is the portal. And as I've said before, now you're taking all this raw data, and that needs to be converted. I've worked on pilots with FQHCs who are doing RPM, and what happens is that if you're just getting raw data being pushed directly into your EHR, into the patient's chart, and a provider has to go through that and sift through all of that data, that's really not helpful. So, Sue is a provider. If she is getting data, let's say blood pressure readings, right? And she's getting what from each patient, and that's what they're pushing into your EHR, is that direct data. And you actually have to go through before you see that patient and try and figure out, okay, what does all of this mean? It really is not helpful to you as a provider or even the care team. What you want to be able to do is to have that raw data be converted into structured data. So what I mean by that is you actually have snapshots, and so you can see what the patient across maybe the 6 months, what's happened in a range, right? And have a graph or something like that, and be able to take a look at that. And then you can make an informed clinical decision. You can say, oh, they started off here, they're now here. I can make an informed clinical decision. I need to change the patient's medication, so on and so forth. And so that's really important. And when you speak with your vendors, making sure that you understand what type of data is being pushed into your EHR. Okay? So that's the secret sauce. The other piece is the alerts and follow-ups, as I said. How are you doing outreach when there is a reading that is out of range, when it's critical? How is that communicated to you as the SQHC, and then how are you then communicating with the patient? Because that's really the secret sauce and the power of remote patient monitoring. So I think one of the biggest things is when you're starting an RPM program is to make sure that you understand how remote patient monitoring, the shift to value-based care, how is that correlating to your strategic plan? So if I have CEOs out there, a lot of times in the SQHC world, what happens is we get grant funding. We're like, okay, we have this money, we need to buy equipment, or we need to spend it, and then 5 or 6 years later, that equipment is usually collecting dust somewhere, right? So really understanding before you even begin, implementation of remote patient monitoring, I want you to think about, how is this related to my strategic plan? All right, how is this relating to improving access to care, and how am I going to get that? And with that, you need buy-in from the whole organization. And so the first thing is to create a team, and that team usually will include clinical operations, finance, QI, marketing. You have to let the patients know that this is something that you're going to be implementing. You have to let your providers know. I was working with an SQHC when there were certain providers whose patients were enrolled in remote patient monitoring, and that provider had no idea that they were. And so making sure that each part of your team and each area understands the value of this program. And then you want to identify program supports and barriers. Very important, determine remote patient monitoring champions. I would say your CMO and a clinical champion for this program, and then making sure that the buy-in is there from the staff and your partners. So really, really important in order to get started. As I said before, a successful RPM program is going to include not only the technology, but also the outreach and the follow-up. Because really what you really want to do is create that behavior change. Empower that patient based on the data to make decisions in their lives, and actually get them from a point of uncontrolled, in this case hypertension, to controlled hypertension. All right, aligning remote patient monitoring with your organizational initiatives, and then readying your patients and staff for the rollout of your program. And as I said, clinician buy-in and buy-in from the clinical team is essential in order to make this a success. And then continuing to optimize procedures and processes on an ongoing basis. So that team that you put together in the pre-implementation phase, the implementation phase, I would say every 6 months or so, you should be getting together and continue to reevaluate. Where are we? Is there anything that we can do better? How do I continue to work with my vendor who you've partnered with to make sure that the program is continuing to improve? So, keys to success: using effective user-centered patient training programs, having sure that you have mechanisms to measure the patient engagement and satisfaction, and making sure that you secure provider buy-in for your program. So before Ben comes in, the really important piece, I think, is the data. And I know this is an HIT symposium, so really, how is the data important? And as I said, once you get that raw data, being able to convert that into structured data, and then pushing that data into the patient's chart. From a clinical perspective, you want that to be able to make decisions for that patient in real time. But then from a financial and strategic perspective, that data is also going to be really important, because as the shift to value-based care happens, and you can show that I've taken patients or my population from point A to point B, when you're negotiating with your payers, having that data is really, really powerful. And so one of the most important things I will say to you is that make sure that whenever you sign a contract with any remote patient monitoring vendor, to make sure that you own the data. You as the AACHC, they're your patients, so make sure that that data belongs to you. I did a presentation in California, and one of the AACHC said they were going through a contract with a particular vendor, and they sent me the contract, the agreement information, and they did not own that data. And I said, you have to have, obviously I'm not legal counsel, but you need to have someone to take a look at that and make sure that is taken care of. All right, so very, very important, because that data, both from an individual patient perspective, but that population data is going to hold you, it's going to be very powerful as we move forward. All right, we can sort of skip this. I know we're running out of time, and if there's any questions on this, I'm around all day, and we can, one more slide, please. One more. All right, so this is the power of remote patient monitoring, right? And this shows within a 6-month period, and you'll see what happened is that average blood pressure reading, this is within AACHC that started it, not just the devices, but really a program to, as I said, create that behavior change. In the first month, you can see the green is normal, yellow readings are cautious, and red readings are critical. So month 1, you can see that the amount of cautious readings were probably the most prevalent. After 3 months of engaging with these patients, you can see that they're starting to change, right? And then 6 months, there's no critical readings, and most of those readings are within normal. Now, this just didn't happen. It happened because they had a plan together. They were reaching out to the patient and engaging them almost on a weekly basis. And the patients in themselves were engaged and were empowered to take charge of their of their health. All right, next slide, please. And this is just a correlation that shows that the more time the health coach or that someone from the care team spent with the patient, the correlation between that and getting that patient from a state of uncontrol to control. All right, so with this, I'm going to, Ben is online. Ben, are you there?
Yes, can you hear me?
We hear you.
Okay, great, wonderful. Yeah, so,
Yes.
thanks to Zephyr for running through that. And I'm sure, a lot of talk about the data, raw, structured, how that's gonna be delivered, to the care team. How can you track that? All critically important. But just as important is for a successful remote patient monitoring program, and I can't emphasize this enough, is when you're consenting these patients, you certainly want to give all patients an opportunity to enroll that you feel could benefit, but also you want patients that are motivated to make a change. We know that's challenging. A lot of patients with social determinants of health have a lot of other challenges that put maybe their chronic disease on the back burner. But as you go through this and enroll patients, you really see that for success, the core is a patient wants to, as Huzefa said, really change their behaviors with the data that you have. And so Huzefa, go to the next slide, please. And what he shared, these are just a couple case studies. So we always want to put patients behind the results and the true impact. And what I know many of you all will see as you start to roll out remote patient monitoring. Here's a case study of a 77-year-old male. Again, these are real FQHC patients. And you want to kind of look at, of course, the details. They have hypertension. They have a connected, for example, this patient had a connected BP cuff and scale, but the patient had goals as well. And that's where the FTE staff is so important for success of this program. You want to tie the data coming in when you can engage them to health coaching, but it all starts for folks that are doing CCM, for example, around what are the patient's goals. In this case, the patient's goal was less pain, a more positive self-image, exercise more, eat well. And the outcome is they cut back on their cappuccinos and ice cream, increase energy. And if you go to the next slide, over time, the patient lost weight. Their average blood pressure meter over 4 months improved consistently. And the patient really felt like they were getting a lot out of the program. And example 2, next slide, Josefa. Another patient that 82-year-old female, history of hypertension, hyperlipidemia, enrolled in RPM, and again, had some goals tied to the data, less pain, exercise more, eat well, and the outcomes where the BMI dropped a full point, and the patient focused on healthier eating to lose weight. And again, if you look at the data and results, next slide, Josefa, how important this is over just over a 3 month time frame, how they really improve their average systolic and diastolic blood pressure and lost weight. And then, Josefa, if you can go to case study 3, and then we'll go to 5 to finish up here. But again, a 77-year-old male, history of hypertension, enrolled in RPM. And so their goal was to exercise more, eat well, lose weight. And again, the outcome was significant. If you go to the next slide, regards to this, did lose weight. And again, that blood pressure over 8 months later was improved. And then if you want to go to the slide, case study number 5, last slide there. Again, a 73-year-old male, history of hypertension, enrolled in RPM. Their goals was to keep their blood pressure readings in range, lose weight. And this patient lost 3 points in BMI. If you go to the next slide, a significant improvement in their average blood pressure and weight over a 7 month time frame. So, this is really the value of these programs. Certainly the data, the integration, all of that's important. But these are the patients that are truly going to have a marked improvement as you start and scale your program. And that's what it's all about. And then, Josefa, you want to go to the last slide. This is, we won't go through in interest of time, a couple of minutes left if folks have questions, but these slides will be available. But if you go to the next slide, working with FQHCs over the last 2 years on some initial early programs, learned a lot about, what's important to be initially successful, try and keep it simple, what you're going to have to do once, and then what's recurring and ongoing. And Josefa touched on a lot of the key things, but always keep the patient first in mind, right? Yes, the data, the integration, all of that's important. Reporting that data to UDS, having providers in the know, but just start, with the patient. What's going to be easiest for the patient to engage in this? And then the other key point from that perspective is what a lot of folks don't think initially about success of this program is the value is being able to real-time engage the patients when they're out of range or when they're struggling with the program, to do that care management, health coaching component to help support self-management and behavior change. And as you all get these slides, they go through these key steps of what you want to think about to be successful with remote patient monitoring.
Thanks, Ben.
Sure.
So with the Medicaid Arizona fee-for-service reimbursement, what that really means for you as an FQHC is, as you think about this, you can partner with a company like Ben's, and what they will do is they'll provide all of the devices at no cost for Medicaid and Medicare patients to you. So you have the devices, they'll do the outreach, and then they're billing for that fee-for-service. What you get out of that is you get obviously the data, and then the improved outcome for your patients. Or you can think about doing a hybrid model where you start and with a company and you just get the devices, and then you may do half and half, like we're going to engage with the patients to try and get our own FTEs, and then maybe have support from a company like CertainTel as well. And so there's different ways to think about this, and just depending on your FQHC. But I will say that the task of reaching out to the patient, engaging them, is something that you have to have, and you may need to bring in additional FTEs or partner with a company that provides that type of service, like Ben's company. Ben, do you want to talk a little bit about the Arizona Medicaid fee for service?
I'll just say I think the overall trend is positive. With the time we have left, is we're starting to see Medicaid follow Medicare's remote patient monitoring program, which is CPT code for getting the data coming in daily, and then the health coaching or care management component of it that's similar to CCM, 20 minutes engaging. Fortunately, Arizona did open up, does allow the CPT fee reimbursement, but it is under fee for service, and we know you all as FQHCs bill under your PPS. But I think the overall trend is that because of the value of remote patient monitoring, payment is improving. They continue to expand it at the Medicare level. We know typically FQHCs like CCM and other tools that kind of follow suit a couple years later. But we're excited to see continued trends from a Medicaid perspective, seeing the value, and we hope that will continue allowing FQHCs in the future to get paid for this type of work.
Yeah, thanks, Ben. And I think that's the frustrating part. Obviously, the HRSA and other entities are providing you with a lot of grant dollars, right, to begin RPM. But you always think about how can we sustain this, beyond the grant funding. And so the good news is I think that we're hopeful that CMS will continue to increase reimbursement for RPM. But my advice and my thing is start now, don't wait. Start with a small population of your patients who really need this, and we can see that the data shows that you can actually really create change for them. So any questions? Yes, see. Yes.
Okay. Good. Okay. So I just wanted to clarify kind of that last piece you were talking about, make sure my understanding is correct. I thought I understood that CCM was still only reimbursed for Medicare patients.
It is.
And that required the 20 minutes time frame documented, right, the care management piece, but that the remote patient monitoring was Medicare and Medicaid, but that was more about just the transmission of data showing that the remote patient monitoring. I guess I'm confused on the 20-minute piece. Yeah. What needs to be documented in addition to showing that we got the transmission of data? Yeah.
That's a really good question. Go ahead, Ben.
Yeah, well, let me be clear. So as an FQHC, you cannot bill for remote patient monitoring for Medicare like CCM yet. We hope that's going to change. We don't see it looking like it's going to change in the next year fee schedule. Medicaid, some Medicaids are opening up under fee for service, again, where you guys don't bill under fee for service typically, are opening up the same CPT codes that Medicare does. So to be clear, what remote patient monitoring is two components to it to currently bill for Medicare. One is how you describe the data coming through. So if you get 16 days of readings out of a 30-day period, you can bill X CPT code. It's around $62 to $64, depending on your region. Then there's a code of 20 minutes, like CCM, of a care manager or health coach engaging the patient around the data that's coming in. And that's a separate CPT code that you can bill within a calendar month as well, which is very similar to CCM. So RPM is in many ways like CCM, but with devices and data coming in. So there's two codes, CPT codes. 99454 is for the data coming in. Again, not to get too in the weeds. 99457 is for 20 minutes of engagement a month around the data. So example, the patient's ranges are out of range. They're coming in and you get an alert. You reach out to the patient, you track that time, and if you engage them 20 minutes a month or even time spent looking at the data, you can bill a separate CPT code under the Medicare program and under current Arizona Medicaid fee-for-service RPM program as well. So I hope that makes it a little clearer.
Okay. Yes. Any other questions? Okay.
And we're more than happy to share. I think Huzefa may be good is just as a follow-up, we'll just share what the current CPT codes and programs are under Medicare and Arizona Medicaid. Again, FQHCs are not authorized to bill yet, but that'll be good just background information once they're, because we hope that will change.
Correct. And so the idea is that you want to, you can partner with a company like Ben's because they actually are a non-FQHC entity, but they have a medical license, and then they can bill. So then they're able to provide you with devices and everything at no cost. So when we're thinking about long-term sustainability, working with a company that can do that will provide you that right now, so that in the long term, when you can bill, you can you already have a program that's started, right?
Yep. I think
So we're aware here at the Alliance that most of you already have picked their devices and are halfway through. So what we're doing, and that's one of the reasons why we brought 13 Tail and video, we have through the grant some hours of consultant services with them. So if you're interested, they're very knowledgeable people. We only pick the best. And we can definitely, if you need it, just reach out to your coach, reach out to us, and we will put you in contact and at no cost to you. So.
Right. I mean, if you need help actually implementing the strategy for remote patient monitoring from soup to nuts, it's something that I've done, across with many FQHC. So we're happy to help. Right. And if you have questions, I'm around all day as well. So feel free to come and talk to me. All right. Thank you.